So thanks very much, Marilyn, and everyone here for inviting me to speak. So I sound strange because I come from the other side of the Pacific, and I just thought there are a couple of points I would pick up on from the day. One is that the FODMAP diet you heard about was the work of Peter Gibson and Sue Shepherd, and the curious thing in Melbourne, where I was based, is that Peter Gibson was my supervisor originally in my early research, and we were all working together in the same place. We were just a few miles apart. And one of the things that was really important about that was that we were able to form a real focus of interest in celiac disease in one city, and that spread throughout Australia. And so very quickly we were able to introduce gene testing, for example, in the early 2000s. I came back from DDW in 1998, having talked to the person that discovered the transglutaminase antibodies, and we set up the transglutaminase antibody test in the hospital I worked in 1998. So I think the beautiful thing in these small countries is that just a few people can impact very quickly and really very effectively and change the whole milieu for a condition like celiac disease. So Australia is now pretty good in terms of awareness, and I think you would find it easy to travel in Australia with finding gluten-free food. The other thing I think I'll pick up on is that about half of what you hear of research breakthroughs are wrong. So they're false positives, they're just research that maybe was done incorrectly, but always remember that when you hear researchers speak about their work, that about half of what you hear is wrong, and it'll be proven to be wrong over a course of years. So we have to be humble, and we have to be able to do good quality research. And the important thing about clinical trials and clinical development is that you usually get caught out eventually because it's so rigorous to get a drug through all those different trials and eventually come up with something the FDA will approve. Okay, so my disclosures: I'm a shareholder of ImmusanT. I'm a patent holder for the various peptides, some of which you've heard about today from my work in Oxford 20 years ago, and I designed NextVax2. So I'm going to talk a little bit about what actually causes celiac disease. I'm not sure we've heard a lot about that today, but it turns out it's T cells. So the interesting thing about celiac disease is that it's not really due to gluten, it's your immune system. It's the immune reaction to gluten, it's not the gluten, okay? So you might hear about the amino acid sequences that are important, but it's actually the T cell, it's the immune response reacting to those peptides. We all of us who eat gluten have those peptides in our bodies. They're not toxic until you have the immune reaction. And that seems to be acquired quite early in life. So for many people with celiac disease, that's occurring between about the ages of 12 months and maybe 6 or 7 years of age. And there seem to be adults who also develop celiac disease. Maybe it's a reactivation of an immune response that was acquired early in life. Okay, so the one, and going back to, I think, Jim's opening comments, you want a cure. So the beauty about immune reactions is that you can cure them. They are not an important part of your body in terms of the way it functions, so you can get rid of immune reactions. And one of the reasons I began my work 20 years ago was because I'd read about these things called antigen-specific therapies. And they're a way of using the trigger antigen for a disease process such that you can reintroduce it and re-educate the immune system so that it no longer reacts in an aggressive way. And it's been shown in lots of animal models that you can reverse and even more easily prevent immune disease by giving the antigen that actually causes the condition. And as far as we know, the only way you can really target and selectively shut off immune responses is by using the antigen or in particular the peptide from the antigen. So there is, in theory, a way to cure celiac disease and other autoimmune conditions. And what we learn from celiac disease probably educates us in how to treat all those other autoimmune conditions like rheumatoid arthritis, MS, type 1 diabetes. The principles of antigen-specific therapy learned in celiac disease, in theory, guide you to how you could treat all of these conditions or even prevent them. Okay, so NextVax-2 is the very first peptide-based immunotherapy in celiac disease, but it's probably more important than that in the sense that celiac disease is the first autoimmune condition in which we really know with confidence what the peptides are that are driving the immune response. So it's become a model system. It's an important disease, but it's also a model system to educate the whole field. We've done several phase 1 studies. I'll show you them in a moment. And we'll be starting a phase 2 study in the second half of this year in the US and also Australia and New Zealand. The other thing that's come out of the work that I'll mention quickly is that we found a way potentially to diagnose celiac disease based on the reaction that we can measure in the blood when people eat gluten just 2 or 3 hours after they eat the gluten. And the markers that we can measure in the blood are from T cells. And it shows definitively that it's the T cell activation that's causing the symptoms, not the innate immune system. So there were really 2 varieties of vaccines. One's prevention, which I think we've probably all had, and they're an effort to educate the immune system to see a virus or a pathogen that you've not yet encountered. It's to set up an immune response that when you do encounter that pathogen, you'll be protected or you get a lesser version of the disease. So flu vaccines, etc. But then there's another whole class of so-called therapeutic vaccines, which are really a way of modifying an already established immune reaction. And they are things like allergy desensitization, which some of you may have had. But we've not been able to translate that so far into the treatment of autoimmune conditions. And we're pretty confident that many of these autoimmune conditions are really because of a very specific immune response. And we know that because of the so-called HLA genes. So any disease which has a strong HLA association that you heard about earlier, really that tells you that there's probably a very specific reaction going on with a particular antigen. But we don't know what the peptides are for most of those conditions. So NextVax-2 is a mixture of 3 peptides. It's specifically for the people who have the HLA-DQ2.5 genetic background. That means about 90% of people with celiac disease. It's targeting the majority of the T cells reacting to gluten. So when I saw a patient, and I'm looking at them over the desk in my GI practice, I know with 90% certainty that this person is HLA-DQ2.5, and I could recite the sequence of the epitope, the peptide that T cells are reacting to. So if you know the HLA type, you know the peptides the person's reacting to. That means you can select the patients who'd be suitable for this kind of therapy. So all of our work has been in people with HLA-DQ2.5 background. The drug itself is an injection, and that's given repeatedly in an effort to initially gradually introduce the drug and then maintain levels of the peptides in the system that keep the T cells suppressed. And our first goal in the drug development program is to control the symptoms related to inadvertent gluten exposure. And as I'll show you in a moment, it turns out that the acute symptoms that people experience when they eat gluten are due to T cell activation. So the drug targets the cell type that we now are pretty confident are the trigger for the symptoms. So we've done a series of studies, people on a gluten-free diet, DQ2.5, either repeatedly dosing them with the same amount, so beginning with a certain dose, then repeating it twice weekly over 8 weeks in a longer study, 16-dose study, or in a shorter one where we had weekly injections over 3 weeks. And in some of the people, we had biopsies before and after the treatment. In others, we were doing a 3-day gluten challenge to find out if we had modified the immune response to gluten in terms of the T cells that were being activated during that gluten challenge. Just briefly, I should have used the pointer, but what we were looking at here was what were the symptoms that people had when they received the injections. And in the screening period, they had a gluten challenge. So 3 days they were eating gluten. This is showing you the symptom score, what we call the GI symptom score. And that went up a bit when they ate the gluten. But then when we gave the very first dose of NextVax-2, we found that they had symptoms which were actually essentially identical to the symptoms they had when they ate the gluten, but only on the first dose. So we could repeat the dose, and the symptoms dropped off, and then gradually, after 2 or 3 doses, there was no difference between the injection and the placebo. So the active peptides were having no effect in terms of reactivating the symptoms. And that turned out to be because the very first dose of the drug stimulated the immune system, and we saw release of what we call cytokines. And that occurred from 2 hours after injecting the drug. And it occurred at the same time as people had the GI symptoms. And the people who got placebo, there was no response. So we saw a coordinated immune reaction being led by T cells, and the red marks here are a T cell marker. Some of these other ones are not from T cells, but it was the T cell activation that came first. So the curious thing about this was that the first dose stimulated a response. This is a panel of different cytokines showing that they went up with the first dose, but on the last dose, it was no different from placebo. So there was zero reaction in terms of the immune stimulation if you repeated the injections. So this meant the immune system was changing. We then showed in a study that we actually could overcome that initial first dose effect by gradually increasing the dose level. So if we began at a very low dose of 3 micrograms and built up to 300 or 900 micrograms, we didn't see those symptoms and we didn't see the cytokine effect. This was pretty remarkable because this 900 microgram dose that we eventually were able to give without causing any symptoms, we think is equivalent to the amount of gluten that would be in 2 loaves of bread. So no one has ever shown anything like this for any autoimmune condition before. But it shows that if you gradually reintroduce these peptides, even though you know they're very stimulatory, the immune system adapts and becomes non-responsive. So we think what's happening is a little bit like what is thought to occur with allergy desensitization. It's a different flavor of immune reaction, but by gradually introducing the antigen, in this case peptides, we slowly shut down the T cell response. And by maintaining high levels of exposure to those peptides, the immune system begins to ignore it. Now, we haven't done studies long enough yet to know if we get out here, which probably takes months to years, before you really know whether you've got a cure. So it's possible that this type of approach could be curative, but we'll need to find that out probably long after phase 3 studies. So it'll take time. So we began to explore whether injecting NextVax-2 peptides, so gluten peptides, in the arm had the same effect as eating gluten. So obviously, if you're eating gluten, the antigen's going this way. It's going to the gut, and many of us thought, and we could never really work it out, is it the gluten causing a toxic effect on the surface lining of the gut and then a T cell response after that? Or is it that it's not having the T cell response until much later? But this shows you that if you introduce the gluten peptides by injection in very small amounts, you get exactly the same cytokine profile as eating gluten. So eating gluten stimulates T cells, the red line, interleukin-2, at exactly the same rate as giving the gluten peptides by injection. So what that means, I think, is that celiac disease is really an immune reaction affecting all your body. It's your immune system. It's not the gut. The gut is where the antigen is being delivered. So the whole of your body's immune system is ready to go and fight the gluten when it's entering through the gut. But it's also ready to go if you introduce those gluten peptides by injection in the arm. So the gut is simply, if you like, the doorway for the immune system. The other thing that means is that if the symptoms are due to the immune reaction and led by T cells, then we have a beautiful way of running trials because we're being asked to look at symptoms. So we don't need to introduce gluten for long periods of time to understand whether gluten-related symptoms are affected by a drug. The other thing it does, it means that maybe we could diagnose celiac disease on what it really is. So if celiac disease is an immune reaction to gluten, it's not the biopsy per se that's important. It's whether or not the T cells are activated by introducing the gluten. That means that if you have someone who's on a gluten-free diet, you don't know whether they're celiac or not because their tests are normal and their gut may look normal. But their immune system is ready to go when the gluten arrives. And many of you know that if you've gone on a gluten-free diet, your symptoms are worse when you have the gluten than they were when you always ate the gluten. The reason for that is that your T cells, because they've not been exposed to gluten, are more reactive. And what we've shown is that the level of the immune reaction we can measure in the blood is directly proportional to the number of T cells that are circulating against the gluten. That means that maybe you could very effectively diagnose celiac disease by the immune markers in the blood 2 or 3 hours after a single exposure of gluten. So, it turns out that if you do that, you find that the people with celiac disease, nearly all of them mount an interleukin-2 response in their blood 3 or 4 hours after they eat the gluten. If you have non-celiac sensitivity patients who are proven to be not celiac, even though they say they have symptoms when they eat gluten, none of them respond. So the work we've done so far suggests that measuring the immune markers in blood is probably as efficient, if you like, as looking for genes related to celiac disease or looking for other markers. And it could overcome the need for a 6-week or 2-month gluten challenge in people who've established themselves already on a gluten-free diet. So there's a whole lot of quite interesting applications, I think, to what we're doing. And we've got a busy year, so we'll be looking at further studies to try and evaluate the diagnostic using blood biomarkers. We have our phase 2 study underway in the second half of the year, But I think the most important thing about what has transpired with the NextVax2 program is that it's probably revealed what celiac disease really is. And it's a T-cell response. And that is something of a relief, because the genetics has pointed to that, but we could never really prove it was the T-cell causing the symptoms. And the other thing that's a relief for me anyway, because I invested 20 years in it, is that it appears that we can reintroduce the peptides and cause non-responsiveness by gradually reintroducing those peptides and being able to inject them at quite high levels. So we're now beginning to work on type 1 diabetes to see if we can do the same thing. So I'm hopeful that it could be that celiac disease instructs the whole research community, drug development community, about a new way to control autoimmune disease. So thank you very much for listening.